what we are going to discuss is out of any syllabus, out of any book, but out of interest because we feel that this practice can help us. So today we are going to discuss practice of fast hug. What fast hug we need? We need to give hug to our patient, right? So whenever our shift changes, we should hug our patient. But we need to hug the patient under what circumstances and but what means. So that my objectives for next few minutes will be for this particular session are that at the end of the session, we all should be able to understand and perform ICU nursing care with more confidence, and we should be able to deliver care to critically ill patients more effectively with simple practice. Now, what is important in ICU? I have a question here for the participants. We have a patient which has come to our ICU post-operatively after knee replacement, and he remains in ICU for 2 days. Now, for that knee replacement patient, who's more important, the surgeon who did the knee replacement or the person who's administering enoxaparin to the patient, right? To me, I'll also always keep the person administering enoxaparin on top of it, everything, because that is the important thing which saves our patient in post-operative period. Any complication developed in post-operative period in ICU is more deadly than a failed knee. And this is the person which gives life to the patient. And okay, this was his job. Surgeon has done wonderful. I do not take any credit away from the surgeon. But to me, the most important person in ICU for a knee replacement remains a person administering enoxaparin. Now, the same stuff comes where there are an endless number of things we do in ICU. We maintain protocols. We build up our own drug dosing depending on our experience, our patients. But the most important thing in ICU is to maintain uniformity. And what happens when we talk of most of the protocols, what is happening there? Protocols is made by the societies and they are followed by the junior members. And what happens to junior members when they follow it? They lose the importance because they think this is written, if I follow, my patient is right. And this was the thing I was supposed to do. But no, there are more important things which we do, you all do. So there are few things which I would put as in routine elements of care, and these are without any formal definition. These all are supportive and preventive care for critically ill patients, which is a standard across the spectrum of presenting pathologies. We all are doing it. And we all agree that any ICU is a very hostile, dangerous environment, and where we need to avoid any complication to the patient while he is staying in our ICU. And to do that, what we have developed and started practicing is bundle approach. And bundle approach is effective means to deliver care to patients in ICU. And this has been developed so that people remember what is to be done and how is to be done. So there are various mnemonics which are designed to cover basic needs of patients so that we don't miss. So the most important word here coming is what we want here is we don't miss what we wanted to do with the patient. And there comes the FASTHUG concept. It's not a new concept. And to share with you all some history about the FASTHUG concept is it was published in 2005 by Dr. J.L. Vincent. And this was just a CME self-directed exercise only. He never imagined that this will become a common practice worldwide. And he also wrote in his original publication that it does not need to be practiced out loud, right? But what happened in 2009 when he realized that many people have got caught of this concept, have started practicing, they also revised it. And so what we have is FASTHUGs, where we have to remember about feeding, we have to remember about analgesia, sedation, thromboprophylaxis, head up of 30 degrees, ulcer prophylaxis, glycemic control, and spontaneous breathing. Now, over the period of time, things have changed and people have started innovating on the mnemonic. And now another mnemonic came, which is like FASTHUG bits. Now, what has happened? Apart from the FASTHUG, we added here bowel care, indwelling catheter, de-escalation of drugs, and control of sore pressures. Another one came there, and they included about skin and eye care and also about the environment. When they take control of these things also into place, there came the FASTHUGs in bed, please. So it became fluid therapy, analgesia, sedation, thromboprophylaxis, head up position, ulcer prophylaxis, glucose control, skin and eye care, indwelling catheter, nasogastric tube, bowel care, and then about environment, temperature control, de-escalation of drug, and psychological support. Is that all? No. Oh, one more has come there. And now this has become Danish Bog Fest. What extra has come here is, again, it's about the environment and skin taken into your routine, which you had already done as de-escalate, analgesia, nasogastric tube, indwelling catheter, sedation, head up, bowel care, ulcer prophylaxis, feeding fluid, and thromboprophylaxis. The bigger one, it came as fat, staph, fungi, badness. Oh, the long one. So what happened here? That 20 things have been taken into one mnemonic, and in one mnemonic, you are controlling 20 things. A smaller one came as faith, where fluid balance, drugs for your bowel motion, investigations and result therapies, and hydration were taken. Oh, one more has come there, favorite thugs. So why they so many are coming up? Because I would say that you can go a step further and you can use an online anagram generator and you can make your own mnemonic. What will happen? You need to look for what are the basic care things I want my patient to receive at least 2 times a day when we change the shift. And when we take a patient, when we hand over a patient, these things should be taken care of and handed over and taken care of. Those things which you think necessary, some examples have already come. And if you look at those things, you can make your own mnemonic, which can be generated with online anagram generator. These are available. So put your thing. If you do not want to use FASTHUG, you do not want to use FASTHUG bits, you do not want to use faith, you can generate your own. But why we are talking about this, that these things help us remember what we were supposed to do, what things are basically minimally required for my patient. And when I do that, my patient gets benefited, number one. Number two, most importantly, we are not missing anything towards our patient if we follow this guideline. So that was the whole idea, that these mnemonics, they are an inexpensive mean to do it. They make our care standardized. So when I go to the ICU, you come to the ICU, those things which we have put in our mnemonic, we want to do in a FASTHUG or some other mnemonic, they are taken care of, and there occurs the uniformity in care. Also, they are found to be time saving because we have those things fitting on our tips, and we finish with everyone, okay, I have taken care of feed, I have taken care of analgesia, I have taken care of sedation, and these things keep on reviewing every shift, because ICU is a very dynamic place and every patient needs changes in either medication or care or any decision we can make. So what happens, that these things help us deliver protocol driven routine care decisions which can be taken and changed from shift to shift. Coming to basic now, if we say that we want to follow one particular protocol, let's concentrate on FastHug, how we can implement it. So FastHug has feeding in it. So we need to look for the feeding for the patient. The energy should be reaching the patient. Calories should be completed. The balance of carbohydrate, protein, and lipid should be made. Then we should take care of.
I will interrupt Dr. Prashant.
Yeah,
how we are going to, what should be the protocol of feeding? When a patient is in
I'll
ICU?
come to the things one by one.
Okay.
We'll discuss in this little detail also.
Sure.
Right. So FastHug involves feeding, analgesia, sedation, thromboprophylaxis, putting a patient head up 15 to 30 degree as per your protocol and patient need, then ulcer prophylaxis and glycemic control. And if we go for FastHug bits, then we need to include bowel care, indwelling catheters, de-escalation of drug, and sore pressure. Coming to feeding first, as Dr. Vivek has raised a very nice question here. So what is happening to the feeding? We agree it is important. It is obviously important. We all need food. We all need energy. We need to balance. It becomes more important in ICU because the patient's energy need changes in ICU, either because of disease or because of its low energy levels, which have come because the patient was already in malnutrition, not taken any food by the time it reached the ICU. And the most important thing here is that these patients are unable to signal their hunger. We are hungry, we'll go and grab something. But patients in ICU are unable to signal that they are hungry. And that's why it becomes more important that we need to take care of their feeding. And there are a large number of guidelines to guide management of nutrition in ICU. We can follow any guideline in our ICU. Further, feeding is important because lack of feed increases susceptibility to infection. There is poor wound healing. There is loss of muscle mass. And it has been shown that there is increased growth of bacteria in gut if patient is not getting food. Also, it has resulted in prolonged ICU and hospital stay. So if we don't go in very much detail, not different, what kind of, what you do, we all practice it. Around 25 kilocalorie per kg per day is a reasonable targeted intake our patient should be getting in ICU. And how we are going to give, we can have either enteral route, which we all follow. We are taking from mouth, let the gut work for the patient, grab the energy out of the food which we have supplied. So what simplest thing we can do as a nursing team or the caregiver in ICU, we should ensure that within 24 to 40 hours of admission to ICU, if not otherwise contraindicated specifically, the patient should have feed through nasogastric tube, right? So as early as possible, preferably in 24 hours, the patient should have a tube which should start its feeding. And simple measures which we need to take care during the feeding is keep the head elevated so that the chances of aspiration are low. Always remember and check position and fixation of tube so that it has not migrated out or in. And we also check about tolerance. The last feed given 2 hours back was well tolerated or it is coming back in the tube. So the tolerance is to be tested. And we do not forget to flush the tube after feed so that the next feed is also we are able to give and the tube is not blocked. But in case our patient is not like where we can have a nasogastric tube feeding started, then we might have to go with the parenteral nutrition. Nowadays, it has become very simple since we have got pre-filled ready-made bags which have all the 3 compartments of protein, fat, and carbohydrate along with micronutrients also put into that. So depending on the patient weight and energy requirement, you can either use 1 liter bag with 1400 kilocalorie or a 1.4 liter bag with 2100 calorie, which will take sufficient requirement of the patient. But remember few things which we need to take care when we are introducing parental nutrition, that we should always use one dedicated line for parental nutrition. Parental nutrition, we are experienced now that it is available either to be given with a peripheral cannula or a central line. There are two different kinds of solutions, and whatever way you are using with that solution, the most important is the cannula should remain dedicated for this nutrition. No drug, no fluid, no handling of that cannula, because what we are introducing to the patient is a best of the culture media. Any handling to the parental nutrition cannula or the port can lead to introduction of any infection. So we do not want that. Take one bag, use it for 24 hours, and then change with the another one.
Uh, Dr.
Yeah.
Prashant, can I interrupt you?
Please.
What will be the conditions when we are not able to start feed in first 24 to 48 hours? Our target is always to start feed within 24 hours or 48 hours.
Perfect.
But there are certain conditions when we are not able to. So what will...
Most importantly, those conditions will remain with the abdominal surgeries, abdominal infections, patients with abdominal compartment syndromes, or the patients having severe septicemia where the gut might not be working because of the ileus, electrolyte disturbances. So the simple things are, we put a rice tube, nasogastric tube, give a saline challenge with 50 ml to 100 ml, check the acceptability and go ahead with it.
Yeah, means if patient is hemodynamically unstable in the beginning, which is very commonly we see in ICU, patient is on the very high inotropic support and we are looking at that lactate levels are very high, then possibly that will be a time not to initiate feed as early. I will try.
Right.
So those patients we should be refrained from feeding them because probably that can be counterproductive in those patients.
Perfect.
And second, one point I would like to add that if gut is preferred route, whenever we are getting an opportunity, until contraindicated, we should use a enteral nutrition rather than parenteral nutrition because it is associated with a lot of complications. And there is a lot of myths about enteral feeding, that how much is the aspiration. It's a very variable practice. If we see that if somebody says 50% aspiration is there with the Ralph's tube, then don't give feed, or 100 ml. So what is your opinion?
In our practice here, you are right. There are different practices with different cities and ICUs. What we follow is that to start with, if it is more than 100 ml aspirate before feed, then we stop, withhold the feed, wait for 1 hour, 2 hours, and then look for it. And also utilize that time to look for other reasons of feed not getting accepted, like lactate levels going up, septicemia building up, any gut obstruction coming up there. So we target the 100 ml of aspirate.
Yeah. Usually it varies from ICU to ICU, but usually it is said that if we calculate that actually value of feed probably may not be a good indicator, but still we have to follow some figures because every hour, if we see the oral secretions, if we see the mucosal secretion from the esophagus and even stomach production, so it is nearly 170 ml per hour. So suppose we have tried a 3-hourly feed, so that makes a 500 of liquids actually passing through the gut, and we are giving suppose 150 ml of feed, so it is making 650 ml total volume. And suppose if 50 or 60 or 70 is coming, then possibly that is probably a no volume. Actually, that is working. So it is a misconception. I just wanted to raise this issue because so many of our colleagues, they have 50 ml aspiration, don't give feed. But yes, if you are having a 200 ml aspiration or more than 500 ml in a day, then definitely yes, you should avoid giving feed. But otherwise, feed should not be stopped. Because most of the time it is a neglected thing in ICU, because ICU is a dynamic area. You are giving antibiotics, you are on inotropes, ventilator. So we feel that feed is not so important, but I believe it is equally important as for any other therapy in ICU.
Very, very truly said, sir. See, the most important part about today's whole topic is that we are discussing the things which should be done daily with every patient, with every shift, And somewhere, unfortunately, we think that these things are not important. What is more important is injecting all the IV medications which are written in the treatment chart. That is why the name fast hug fascinates me always, that this is the hug which our patient needs, and this will not transmit any disease, but this will only transmit happiness to the patient.
Very true, very true.
So the next thing in FASTHUG comes as analgesia. And whatever patient we receive in ICU, there can be many reasons for the patient to have pain or feel pain. This pain can be because of illness per se, direct illness. If we receive a trauma patient, we receive a post-operative patient, we receive a head injury patient, or a neurosurgery operation patient, or if even without trauma or without any surgery, then as soon as you receive patient in, you put a lot of tubes. So endotracheal tube, Ryle's tube, even the suction catheter which is going near the patient, or the IV cannula, even central line when put, every procedure or the instrumentation done has pain. So we need to give analgesia because of the patient comfort. And if we comfort our patient, reduce the pain, it will also reduce the stress response to the patient. So we calm comatose patient is easier to look also. So from nursing perspective, if we have a patient which is cooperative and does not have any reaction to, means does not have pain, then it would be more cooperative. And if we have unrelieved pain in ICU, I would say it is nearly a crime that we are denying pain relief in ICU. To assess the pain relief in ICU or the pain presentation in ICU, what we can assess the patient with visual analog scale, which is VAS, and this can be presented from 0 to 1. So simply what you are asking, 0 to 10, what you are asking someone if the patient is cooperative enough. This is more for our awake patients which you receive on care. But lying patients, not sedated, cooperative, can also tell you about this. Other way to do it is, since it's a visual scale, that you can look for the faces of the patient. If the patient is calm, comfortable, smiling, then it would be zero pain. But anyone having a very bad pain, it reflects on patient's face that yes, patient must be in pain. Apart from other parameters of hemodynamics, when you look for heart rate, blood pressure, that might be another manifestation, but ICU has its limitation in the heart rate and blood pressure to show. And what type of analgesia we use? You always use from simple paracetamol, acetaminophen, to going up to weak opioids of tramadol or strong opioids of fentanyl, to putting patients or continuous pain pumps with epidural or nerve blocks. So we always go with the ladder, which is also approved by WHO, and from acute pain to chronic pain, also the ladder has its own importance. So we already said that what we have in ICU to use with drugs which are should be high potency, fast acting, short duration, because we do not want any drug to have longer effect so that we cannot assess a patient later, and minimal side effects. What we generally use is acetaminophen NSAIDs, or when we come to the opioids, we use morphine and fentanyl. Dexmedetomidine and ketamine is also not very uncommon. Dexmedetomidine is quite common in my ICU, although ketamine is not so commonly used in my ICUs. And for post-operative patients, we also receive patients where epidurals or nerve blocks are working for the pain relief to the patients. Coming to the third point, it's sedation. So what happens that intubated patients especially need adequate depth of sedation for two reasons. One is to make them comfortable, and when we use word adequate depth, we mean a depth where we need to have a point of assessment also. We do not want patients to go too deep also. To assess that, we can either use Glasgow Coma Scale, or we can use Richmond Agitation and Sedation Scale, or what is called as RAS scale. So it should be thought about regularly about sedation, because it's not like when we have started an infusion of sedation, it continues for forever. We need to have repeated assessment, and after repeated assessment, we need to titrate the drug also. So it also reduces our healthcare cost as well as stay in ICU. Another point.
Sorry, Dr. Prashant,
Yeah.
for sedation and analgesia, what once the patient has become stable and we feel so, should we try a daily weaning protocols, or should we try these things?
Yes, that point has been, I've taken it little back with the spontaneous breathing trial part, where we will be stopping the sedation daily to assess. But yeah, that is very important thing and practice.
And for analgesia and sedation, do you prefer more of the infusions or a bolus doses?
We prefer more of the infusions.
And what is the status of propofol, use of propofol in the ICUs?
Propofol, yes, for patients which we want to have deeper sedation. The most common drug today is dexmedetomidine for my especially neuro patient. They are coming comfortable because it takes sedation as well as analgesia with one single drug. Coming to the next point, as thromboprophylaxis. So for thromboprophylaxis, if we look at the physiological triad, where there is hypercoagulability, vascular damage, and circulatory stasis because the patient is lying in the bed. These three things make our patient in ICU very susceptible for any thrombus generation. So any thrombi generation, moving it, we will be calling embolization. So thromboembolism is the deadliest thing to have in ICU, because if it goes and blocks our heart or the lung or any other end artery, we really are in trouble. The patient is in trouble. So it is the most important and thing which should be taken care. Every shift we need to look for what thromboprophylactic measure is being given to this patient which is bedridden. If no prophylaxis is indicated for any reason, that should be documented why we are not giving this patient thromboprophylaxis. And there can be reasons. There can be reasons of excess bleeding. There can be reasons of coagulation abnormalities. There can be reasons of renal profile because of which we are not using some drugs. So that should be mentioned in file. Otherwise, each patient should be receiving thromboprophylaxis. Now, thromboprophylaxis can be given with either mechanical method. It's not necessary that every patient would receive graduated compression stockings, or we can be using elasticated stockings, or we can be using sequential compression devices. Right? These are simple devices intermittently pumping the air to the stocking which is given to the patient. And most importantly, if we have a protocol where we have early mobilization, then beyond this, we will be withdrawing thromboprophylaxis. So pharmacological agents which are available and commonly used are either low-dose heparin, low molecular weight heparin like enoxaparin or deltaparin, depending on patient's weight, or the newer agents which are also coming up will be in future more and more in ICU, like apixaban, dabigatran, or rivaroxaban. Presently, for my personal experience, these drugs are more in use when we send patient out of ICU, and in ICU, we are still more happy using enoxaparin or deltaparin subcutaneously.
Prashant, can I add something with the sequential compression devices, especially because the everybody who's working with this should be aware that suppose a patient is bedridden for maybe 2 days or 3 days, and you have not put the sequential compression device. So it is important that we get a venous Doppler done before putting these devices, because it is possible that the patient has developed some thrombus, and when you use this sequential compression device, that thrombus can break and lead to a pulmonary embolism. So this is one. Second, for sequential compression device, always in every shift, nursing staff should have a protocol to take off the sequential compression device for 10 to 15 minutes, because otherwise probably there will be a development of some pressure sores or those things, and you should leave for it for 15 minutes, but never forget it to restart again. And by that time you just inspect the leg for any soreness or any change in color or any other complication associated with these devices.
Rightly said. Rightly said. Yeah. So coming to then positioning of the patient, H for head up. So it's around 30 degrees head up. We all agree that we keep our patients up because supine posture is associated with more chances of aspiration. So to prevent the aspiration and ventilator associated pneumonia, if not contraindicated, like we need to avoid it, hemodynamically unstable patient, pelvic fracture patient, or spinal injury patient, where we might not be able to head up the position. Otherwise, every patient should be positioned head up, so preventing the aspiration. Then the patients who are coming to ICU, they are at very high risk of developing gastric ulcers, and it might be because of the stress conditions, or it might be because of the drugs being used, steroids being used. So ulcer prophylaxis becomes an important part of any treatment protocol, and it can be in form of H2 receptor antagonist or proton pump inhibitors, or otherwise oral antacids. All three can be used for ulcer prophylaxis. One more thing here is that as we give enteral nutrition, it also helps in ulcer prophylaxis to our patients who are in ICU, bedridden, and they are at stress. Glucose control, we need to have a glucose control, and we are happy to have a control between 140 to 180 milligram per deciliter. And especially important for a patient with a prior history of diabetes, we need to have adequate pharmacological control. If the patient was already on drugs, we need to look at what drugs, what dietary factors are responsible for it. And most of the time, our ICU patient would be on short-acting insulin infusion or subcutaneous infusion, or nowadays we have already started using longer-acting insulins for the night, so that the fasting controls, they come better. So we need to avoid hyperglycemia, hypoglycemia, which may lead to either increased mortality or end organ damage also. Now, coming to interesting point, spontaneous breathing trials. So this is something which is most, I would say, least importance given part to any ICU patient, where we start sedation, we start mechanical ventilation, and when we forget it for next 2 days, 3 days, 4 days, till we find some sudden changes and start, oh, we haven't tried it. We need to have a protocol where we can daily stop some sedation, we give it a vacation from sedation, and give it trial of spontaneous breathing. It not only stops the sedation, brings the levels down, but also gives us the assessment to the patient, whether the patient is able to generate breaths, what kind of breaths, how the lung is behaving. That clinical assessment is very important and informative, and having a daily spontaneous breathing trial is a very important and safe practice. You want to add, Vivek, something to this?
Can we go back on the slide? The previous one. Blood sugar control. For blood sugar control, I have few points to say. especially those patients who are on shock. Their subcutaneous administration of insulin administration may be very erratic. So in those conditions, it is preferable to have a infusion in these patients until the patient has become hemodynamically unstable or out of shock. And second, hypoglycemia is more detrimental as compared to the hyperglycemia. So one has to be very, very careful, because identifying hypoglycemia will be a bit difficult in sedated and ventilated patients. So one should have a high suspicious when there is unexplained tachycardia or unexplained sweating in these kind of patients, then possibly you should always have a habit to check the blood sugar levels. And your previous slide before this, before blood sugar, yeah, for ulcer prophylaxis, again, this FASTHUG are all these protocols what we follow. These allow us to understand or quickly identify the drug related errors or complications also, because what happens so many times, we add a proton pump inhibitor, along with that we start adding the sucralfate for the ulcer prophylaxis. So these becomes, sucralfate will not work until the gastric pH is less than 4 or 4. So giving TPI or H2 receptor antagonist possibly may not be beneficial. So these kind of, and moreover, we will keep adding on the drug and we are creating complication. So we should avoid adding these kind of combinations. And moreover, by doing this FASTHUG or these protocols, possibly we can reduce the chances of complications associated with the drugs. Thank you. Can we continue?
So if we go beyond FASTHUG, now we are adding bits to it, and it involves bowel movement. So we cannot leave a patient who's constipated. That means 3 days not able to pass stool, or a diarrhea, which would be anything more than 3 to 4 times per day. Now, if we have a diarrhea patient, then we also need to look for whether we are dealing with a non-infective versus infective diarrhea. Most of the time in ICUs, what we have is non-infective diarrhea, which might be because of physiology or the drugs which have been pushed to the patient. So constipation, simple causes can be our drugs, opioids, or it can be dyselectrolytemia, or the patient is in ileus because of dyselectrolytemia or other reasons, bowel edema, or there can be direct intestinal obstruction. Another point which we need to look daily is taking care of catheters. And ICU patient most of the time to us look like this image, where there are poles, wires, and catheters. So all types of tubes in, and these are the patients where we should be looking for each and every catheter, which should be cared daily. Another important thing which we should practice is de-escalation of drugs. It's not that once we get a patient, we put highest of the antibiotics and then we continue it. And so de-escalation of antibiotics is important, and we need to follow the antibiotic policy of our hospital, and we should switch to the antibiotics as soon as we get the culture results from the broad spectrum to narrow spectrum as per the culture sensitivity. So this has been included in this FASTHUG BITS protocol, because it's not that the doctor, the senior doctor, junior doctor who comes to the round and writes an antibiotic and that is the line. No, that is not the line. That is the line when we started it. But when we get the results, when we have sent the cultures, if we put it in our protocol, then we can have a discussion. Now the culture report has come. This is the bug. This is sensitive to this simple antibiotic. Can we de-escalate? And de-escalation of drugs can also be taken not only for the antibiotics, but also to our sedation, cardiac drugs. So every drug can be de-escalated if looked upon for on daily basis. So what we need to do to appropriately start practicing these practices is that there are points in favor that this is acceptable, and most of the time our ICU staff, they tolerate it fairly well. These are simple things. These things help in better communication. We all have the same language, that I have done the FASTHUG, these are the problems with the patient. This can also help us decrease the ventilatory associated pneumonia rate. And care bundles in general has a tendency where their greater organization is there and there is decrease in inefficient variation. But there are points against it also, and I'll agree with you that if you say that no protocol should encompass the decision making possibility, right? So there has to be flexibility for each and every protocol we follow. And if we are coming to FastHug, so that we do not forget, this does not mean that we stop using our mind with each and every patient which might have a different need. So a mindless application should be avoided. We need to put our brain that what my patient might be needing and I should look for. And this is also only a protocol to guide us. If we follow it blindly without putting our mind, it may become a cumbersome practice to us. So we need to adapt to it. To summarize, using any protocol in our daily practice to look for the routine need of the patients improves quality of patient care. It increases safety and efficiency. It helps us not to forget the routine things every patient needs on daily basis, and definitely it improves our teamwork. Best wishes for your patient, and I would say stay safe, stay away from corona.
Wonderful presentation, Dr. Prashant. You have covered each and every aspect of the FASTHUG. In fact, you have gone beyond that. And I'm sure that using any checklist of this kind, especially this very simple mnemonics, it can reduce the lot of ICU errors, not only ICU errors, but even the de-escalation of medications. Because if a patient is admitted, say, for 10 or 15 days in the ICU, then there is a tendency that we keep adding the drug, but we never de-escalate the drug. Then possibly this will be very beneficial to de-escalate the drug. But the only thing recently, what I'm seeing, that there's a lot of checklist in the ICUs, and the staff is busy in the filling the checklist rather than actually providing the care to the patient. So to all listeners, I'll say, always, as Dr. Prashant said rightly in the beginning, fast hug your patient, daily. So you have to be honest towards the patient that we are doing, we are making all documentation after completion of the care, not just filling the chart for sake of filling the chart. Because these, as he rightly said, that these are just a guidelines, and you have to use your brain. And applying these practices, implementing these practices can definitely improve your patient cares in a significant fashion and will reduce the chance of error significantly. So I'm sure this talk will be was very beneficial to all the participants. Dr. Prashant, we had one question. I have answered it on the on the message. Somebody was asking about the refeeding syndrome, that what it is and how to handle. So I've just answered, but you can definitely answer if you can add some more things.
Not very common, but it's not like that it's uncommon also. When a patient from ICU, a long stay, and after a very long period, when we start feeding the patient, then we start getting more anomalies of electrolytes and gut anomalies also. So they all go into the refeeding syndrome, where we might need to even stop feeding for some time and restart it with smaller doses, simpler molecules, and then the patient body adopts to it.
Basically, what happens most of the time, if you have not fed your patient for a long time and patient is having hypophosphatemia, especially when the phosphate levels goes less than 1, then they suddenly, once you feed them, they become very tachycardic, they become sometimes hypotensive even. And the moment you replace, you can see the dramatic response. The moment you replace the phosphorus, which is available with the name of POTFOS, and you can see the dramatic response that the tachycardia starts settles, and gradually when you start with a smaller quantity of feed, they start tolerating these the feed most of the time. Another question, gastric residual volume, somebody was asking. So Prashant, any comment on the gastric residual volume?
See, gastric residual volume is the liquid which is retained by the stomach after any enteral feed which is given to the patient. All right. And the larger the volume, the more chances of having passive regurgitation might come. And inflammatory conditions, they result in more of it. Infection, inflammatory conditions. So enteral nutrition might be tough, as we started discussing in beginning, that inflammatory and infectious conditions where this volume becomes more impactive.
So basically gastric residual volume is too high, then you are worried about feeding or not to feeding your patient. So in a day, we had discussed earlier during the feeding, that usually every hour it is nearly 170 ml of the total volume which is reaching to the stomach. So suppose you are feeding after 3 hours, it's nearly 500 ml, and you are adding a feed of 200 ml. So it is 700 ml volume actually you are pushing, keeping in the stomach. And your aspirate is 50 or 100, it is not a big deal. But yes, if it is coming more than 500 in a day, or in a single feeding, if it is around 200, then you should avoid, or you should use other measures to increase the movement of feed. One of the measure which is very important, that turn your patient left side up, because with the gravity, the feed will move further. This is one of the very good technique what we follow routinely, rather than adding any prokinetics or any other drug to move the feed further. And most of the time it works, because most of the time these patients are lying on the bed, their gastric motility is compromised, they are having fluid shift and lot of gut edema. So this strategy, lot of time it works. I hope it will help everyone if you are practicing in your ICUs. Any other question? I'm not finding any question in the question answer session. So any other comment?
Sir, we have a question.
Yeah, Dr. Ramesh.
Dr. Ramesh from college. I'm sorry, I had some trouble logging in, but I saw that you had started it on time. So thank you very much, Dr. Vivek and Dr. Prashant. It was an excellent, comprehensive talk. Just one comment on the gastric residual volume, if I can.
Please.
There is one study that showed that it probably doesn't matter what the gastric residual volume in terms of ventilator-associated pneumonia. That's the worry that we would have in terms of microaspirations and VAP. That study showed that whether you check GRV or not, the incidence of VAP was not different. So that's something I just wanted to add to whatever.
True. Very true. Absolutely right.
You both said. Otherwise, it was a fantastic talk, Dr. Prashant and Dr. Vivek. It was very lively moderation, and I think you addressed all the key points. I can't thank you enough on behalf of the college. Thank you so much.
Thank you so much, sir. Thanks the audience for joining in good number. That's very important for us.
We have few chats, I believe. I just wait for Prashant.
Yes, sir. Yes, sir. If there's any questions, you can take it. We have some time, sir. We have another 8 minutes time.
Kindly tell the gastric residual. Do we need to follow and check it every time? Yes, Prashant, would you like to comment?
See, if the patient is like when we are checking about the feed and the enteral nutrition, every time when you are giving the next feed, you really look for if there is active aspirate coming out. If that is coming out, we really need to check with every feed. If it is going smooth, we do not need to aspirate before every feed. Generally, we do not aspirate before every feed in that situation.
But one thing I will add, that we should always check the position of RALS tube, and if you are that has to be checked every time. And second, if it all depends whether you are using a bolus for giving feed or you are using a bag for continuous infusion. Never aspirate if you are giving a continuous infusion. But yes, if you are giving bolus and you are in doubt, as rightly Dr. Prashant said, then definitely yes, you should check for the aspirates, gastric aspirates.